This presentation is actually a really good way to end because it takes us back all the way to the beginning and rethinking what our research question is, given that at the end of the day, an impact evaluation is itself an intervention, right? There is a world in which there is an impact evaluation and there's a world in which there's no impact evaluation. Hopefully, our theory of change is such that in the world with the impact evaluation, we are actually able to make better informed decisions and better informed policies going forward. And so Rachel's going to talk a little bit about that and how we might want to be thinking about designing our evaluation so that we're answering questions that actually can inform decision making later on. So thank you very much.
Okay, great to be back. So I have called this globally informed, locally grounded decision making. And what I am going to talk about is how to use the results of impact evaluations in making decisions. And sometimes we hear about, we think about, well, should we be talking about or using evaluation results that have been done elsewhere, and that's put in contrast to should we be using evidence and knowledge that's locally grounded. And what I want to talk about is how to combine what we've learned at a general lesson from around the world and what we know locally too, because I think both of those are extremely important. Oh dear.
I think it's this guy needs to be.
Do you need to reset it? Ah, here we go. And so this is part of a more general issue of when and how can we generalize from a study that was done somewhere else. So I'm going to start by talking about the challenge that we face, and here I'm going to be talking in the voice of or assuming that you're a policymaker rather than a researcher, trying to use the evidence from an impact evaluation. And then I'm going to go through a couple of examples. I'm going to set out a theory, sort of theoretical structure of how you go about thinking about using evidence from other contexts and when it's relevant to your context. I'm going to go through a couple of examples and do a little side note on what this means about using literature reviews and meta-analysis. So the basic challenge that we face as a policymaker is that while there's been a dramatic rise in the number of impact evaluations that have been done around the world, it's very unlikely that if I'm a policymaker facing a very specific question in my context, it's very unlikely that someone has done a high quality impact evaluation of exactly the question that I care about in exactly the place where I'm working now, right? So that raises the question of what do you do? Well, we could just wait to act before we have enough, until we have more evidence. Let's just wait until we have an impact evaluation answering exactly that question, exactly in the location. Or we could say, well, there hasn't been an RCT here of this question, so I'm going to have to do one. Or we could say, well, we don't have rigorous evidence in this context, so let's rely on less rigorous evidence from this context. Some people have advocated just, looking at correlations locally, and that's better than using a rigorous impact evaluation from another country. Or you could say, well, no, I don't want to go on correlations here. If someone's done a causal evaluation, a rigorous impact evaluation somewhere else, at least that's better. At least that was rigorous, so I'm going to take the evidence from that. Another thing people often say to me is, well, how many RCTs of a given question do you need before you know that something generalizes? And that suggests what they're saying is, if you've done, 4 or 5 RCTs in different contexts, maybe different cities in the US or different countries around the world, and you always get the same result, then you know that the result generalizes. Well, I just think all of these are not the right way to proceed, and I'm going to try and persuade you that in this talk. I think, in particular, there is no magic number that says if it's replicated in 4 places, then we know it'll replicate in a 5th. Right? That's not how the world works, I don't think. So you might say, well, maybe if it worked in a similar place, it'll work here. What do we mean by similar? So I'm going to try and set out a framework for thinking about these questions. When can we use evidence that was generated in another context? And how do we incorporate what we know about the local context to interpret the evidence that has been generated elsewhere? Because I think we have to understand, we've been persuading you throughout this course that doing rigorous impact evaluation is important and useful, and obviously that's what I spend my life doing, so I think it is important and useful. But it can't be always the answer to everything, because it's hard to do these studies. I mean, you're learning as you're doing this course, you're understanding just how much sample size you need, just how much data collection you need. It's not trivial to run a randomized trial. And so if we only use a randomized trial for that one question in that one place, I think we're really underutilizing the results of all this work. We've got to learn from other people. The question is, how do we learn from other people? How do we learn from other people and yet stay true to what we know about our own context? And I think one approach is to do more randomized trials replicating the same program, but again, that's not the answer. We can't always continue to replicate. Like, how many do we need? Like 100, 200? That's not the only answer. And I think part of understanding this is recognizing that we will never have 100% certainty when we make a decision as a policymaker. Now, this may come as a surprise to academics. I don't think it comes at all as a surprise to policymakers. Of course, we never have 100% certainty when we are making a decision about whether it's going to work. We have to make the decision of what is the best evidence that we can use as we try and make a decision. And is imperfect evidence worse than no evidence at all? So as I say, what I'm going to do is put forward a structured approach to using evidence in policy. And that's going to recognize that any one study is only one piece in a puzzle. It's one bit of information we have, but it's only one bit. And there's lots of other pieces of information we can use and should be using. We can use theory, we can use descriptive evidence, and we can combine those with the lessons from rigorous impact evaluation to project what we think might happen in a new context. And it can help us tell us, when we'll need to do another evaluation or where we think we've probably got enough evidence to start working on. In what I'm talking about, I'm going to draw on a literature review that I did of over 70 randomized trials on health programs in developing countries. So let me start with an example. This was a study that I did with co-authors in rural Rajasthan, looking at how to increase immunization rates in this poor rural part of India. And there were 2 challenges. When we did our needs assessment, we saw 2 challenges. One was that supply was a problem. So, like in many places in the world, there was very high absentee rates of nurses. And these were single nurse centers. So there was one nurse in the sub-center, and if she was absent, the clinic was closed. And 40% of the time, the clinic was closed. So you can see that's a real deterrent to coming and bringing your kid to be immunized. You walk all the way there, and the center's closed. So in order to fix that, we organized to have regular immunization camps. So absolutely, without fail, there will be a nurse at this point, every Monday, the first Monday of a month, and that would test whether the problem was the supply, the supply issues that the nurse wasn't turning up. The other potential challenge is on the demand side, particularly because immunizations are things that happen, they give you reward later in life. It's very hard to see the benefits of an immunization. Your kid might not actually be exposed to the virus they're getting immunized against. And so plus the benefits are further down the road. So we looked at giving a small incentive to promote the idea of immunization. So you get a reward today if you get your child immunized. So in this context, it was a kilogram of dal or of lentils people received for every time they brought their child to be vaccinated. And at the end of the vaccination schedule, they got a set of plates. So it was very salient to them that they'd reached the end of the schedule. If I haven't got the plates, I clearly haven't finished the immunization schedule. And this is what we found. So this is the number of immunizations received, or the number of visits, really, because you can get several doses in a visit. And you can see that, and the red is the comparison group, and you can see that over 50% of the comparison group were getting one vaccination, but only 6% of the population was being fully immunized. So really, really low rates of immunization, much worse than many parts of sub-Saharan Africa. The immunization camps, fixing the supply, making it easy to get vaccinated, had a big impact on getting at least one vaccine. But again, you see this very steep tail off, so that by the end, there was no significant difference in the levels of full immunization. Adding the demand incentive didn't actually affect much at the beginning, but it helped people persist to the end. Now, this is starting to tell me something about what's going on with why people aren't being immunized. And it's a pattern that you actually see all the way around the world. So it wasn't so much that people feared vaccinations. They were willing to get one vaccine. What was the problem was they weren't persisting through to the end of the schedule. And this very much fits with behavioral economics theories about us being able to persist in behaviors that are good for us. So things that we have to do regularly. We don't exercise enough, we don't eat properly, that we know that's good for us, but we have to keep, we have bouts of enthusiasm at the beginning of the year, after our New Year's resolutions, but we fail to persist over time. Right? So this is a very common pattern that we see. And as I say, these data are starting to tell us about the theory of why this might be a problem. Now, if we take that study and say I'm advising a government in West Africa, which I am, which is faced with problems of low levels of immunization, should I advise that country to consider an incentive to increase vaccination rates? Well, if I just take that study in isolation, I would say, you've got to be crazy. We've got one study that tests this. It was in India. You're talking about West Africa. It was with an NGO. You're talking about working with a government. It's completely different context. How can we learn anything from it? What I want to argue is that this is the wrong way to look at the evidence. we don't just have one study. We shouldn't, if we just look at it in this kind of simplistic black box approach, how many studies have tested a small food incentive leading to an increase in vaccination rates? There's only one study. But if we think about the theory of change behind that, we will end up with a lot more evidence. So this is what I call taking apart the black box. What was the theory of change behind our study? It was that parents actually want to immunize their children. That's the theory, that's the assumptions that we're making. They have to be able to access a clinic, and that's why we fixed the supply issue in this context, because this context needed fixing the supply issue. So they have to be able to access clinics. But parents procrastinate and they put things off and they can't persist on things that have these long-term benefits. But we know, or we think we know, that small incentives can offset procrastination and can help people persist. Then we have kind of the logistics issues of you have to have incentives delivered to the clinic, and the incentives actually have to be given to the parents, right? Which is kind of, the logistics have to work, and that leads to higher immunization rates. So we have these things that are local conditions, locally relevant, these things which are really about the general psychology of people, how do people behave, and then there's a set of questions about implementation capacity. And I think the kind of evidence that you need to answer these different questions is very different. And so to say, do RCTs generalize, is kind of a stupid question. What you want to ask is, does that generalize? Does this generalize? Are the local conditions relevant? Are these general behaviors? Do the general behaviors generalize? Is implementation relevant in my local context? So you would use different pieces of evidence, of which RCTs are part, but only one part, to see if this program might be relevant in our context. So let's go through, in this example, let's go through a bit of detail about what do we know about whether this might work in West Africa. Well, the first set of questions are about whether parents want to immunize their kids and can they access clinics. And I know, because I've done descriptive work in this context in Sierra Leone, I know that it's quite hard to access clinics. Actually, a lot of people live quite a long way from clinics, and health worker absenteeism is quite high. However, I also know that the vast majority of parents manage to get their kids get at least one shot. In fact, that is higher than we saw in India. So they're actually managing to access clinics. And part of the reason is this institutional knowledge, which I also have, having worked in India and Sierra Leone, which is in India you have these small sub-centers. One nurse is gone and the whole thing is closed. In Sierra Leone you tend to have bigger clinics. And so if one person is away, it's still probably open. And it's also the day that it's most likely to be open is immunization day, Child and Mother's Health Day. This is common in a lot of places. There are certain days a week, and they're always open and they're always busy on those days. So actually getting to the clinic and getting your kid immunized happens, as we see, at least once. Indeed, that take-up rate is going to tell me a lot about what's going on and what the problems are. This is slightly stylized, but look at these two different countries. This is the immunization schedule. This is the early immunizations, and measles tends to be the last one, and then the rate of fully immunized. Now, which of these patterns do you think would be a good place to try the program that we tested in India? Just looking at that immunization schedule, which is kind of more similar to the problem that we faced in India. Sorry, I don't have clickers, so you're going to have to put up your hands and respond. Yep. Country one, why?
Because it starts with like very high immunization and then gradually decreases.
Right, so country one, we're seeing this drop off. We think that actually people can access the clinic because they're getting at least one, but we're seeing this drop off, which is what this incentive is designed to combat. Country two, there are a lot of people who don't even get one, so either they can't access the clinic or there's some objection to immunization. This is kind of slightly stylized, but this is sort of northern Nigeria and Sierra Leone. And, where you might have some cultural hostility to immunization or access issues, there isn't actually much drop-off. Like the people who do get the first one may persist, so they don't seem to have a persistence problem. Right? These are both West Africa, but they're very different immunization schedules, and they're telling me something about what the problem is. Now, if we go back and think about what's the next step in our theory of change, the next steps were about these general behaviors that people procrastinate and that they have present bias. So they find it hard to make investments now for benefits in the future. Now, there's a lot of good theoretical work on present bias, and there's a lot of interesting RCT evidence suggesting that this is a problem. The most telling of which is that people, in a number of contexts, people are willing to pay to tie their hands. They will sign up now to give themselves less choice in the future. That is completely contrary to any kind of standard economic model, and the only thing that really explains that is that I know I'm going to make stupid mistakes tomorrow, right? So I'm going to force myself to have less choice so that I can't make those stupid mistakes tomorrow. I know I'm going to procrastinate tomorrow. I know I'm going to not save tomorrow. I know I'm going to eat badly tomorrow. I mean, we all do this. Like, we don't buy the cookies because we can't trust ourselves not to eat them, right? That is a form of being self-aware that you're present biased, right? And you're tying your hands. You don't have to eat the cookies if you buy them, but we know we can't stop ourselves, so we don't buy them, right? We don't have them in the house. So in some ways, it's very intuitive. It's completely contrary to a standard economic model where more choice is always better, but we have a lot of evidence that humans act this way and in fact are willing to pay for someone to take the cookies away from them, or pay to save, for example, force themselves to save. So now there's also a lot of evidence that small incentives can offset present bias. So there's more than 30 RCTs on conditional cash transfers where large incentives get people to immunize their kids more. There's evidence from Malawi that if you give a small incentive, it's just as effective as giving a big incentive. And then there are a bunch of other projects that test small incentives having an effect on health behavior. So everything from picking up HIV tests to age of marriage, the study that we talked about in my last lecture. So there may be only one RCT looking at this specific program, but we actually have a ton of evidence that small incentives are effective in changing behavior where that behavior is about procrastination. Here's another set of evidence that's relevant. Rather than small incentives, this is sort of the flip side of that, which is charging for preventative health. Right? So if you have a slight increase in the cost of preventative health, you see a dramatic fall in the take-up of preventative health care. This has all come from developing countries. My guess is probably a lot of this would hold in the US and the UK. There's a lot of debate about making contraceptive free, for example. And, if you think about the costs of having a baby, the costs of contraception is really kind of neither here nor there. And yet we do actually think that the cost of contraception will change whether people use it, which is an example of how small costs can affect behavior that has long-term big impacts. So this is deworming pills, bed nets, disinfectant for water, adding chlorine to water, soap in different countries, and we see it's a very similar pattern. So again, it's telling us the same thing. People are very price sensitive, either small incentives or small costs, you get the same effect, big changes in behavior. So again, it's not an RCT of incentives for immunization, but it's telling the same story about how people behave, and it's showing that that is common across the world. Here's another piece of evidence. This is look about price sensitivity and how I at least believe that it is then linked to these behavioral biases. This is from a deworming study that looks at, that calculates the net present value of the higher earnings people make because they were dewormed as children. Right? So the Bennett, you earn $142 more if you were dewormed as a child in net present value terms. Now, and yet people won't pay 50 cents to get dewormed. If in a standard economic model, that would suggest that that's because the costs must outweigh the benefits. So the costs of, the stomach upset that you feel if, sorry, just after lunch, guys, but, if you've got a lot of worms in your stomach and you get them killed, it makes you feel a bit queasy, right? Maybe that's the cost. You've got to have some reason why people are not willing to pay 50 cents, 40 cents for this pill. And yet, when we take off, 40 cents from the cost, we actually find that the calculation flips. And that's kind of really odd, right? That suddenly all these people move in this big cost-benefit calculation of 40 cents. Everyone's just on the margin of 40 cents. Well, what makes more sense is that they're just thinking about the costs and benefits today, and therefore 142 is years in the future. So you're focusing on costs and benefits today, and so the 40 cents seems quite big then. So we think there's a lot of evidence that people don't invest in these long-term health benefits. They're very price sensitive. Small incentives therefore may work. But what about local implementation? That's the last bit in our theory of change. This is where the evidence from India is not so relevant. Because the fact that a really good NGO can pull it off in India doesn't mean that a government in Sierra Leone can pull it off, right? This is where switching from an NGO to a government is relevant. But the question is, if I'm worried about implementation capacity, should I be doing an RCT? Like if my question is, can the government pull off running this program? Do I need an RCT to answer that question? No, you can tell by the tone of my voice. I'm asking you to say no. You're very confused because you've come to this course to learn about RCTs, and here I am, the executive director of JPEL, telling you don't need an RCT, right? You're all very nervous of saying that. Well, no, we don't think you should do an RCT for everything. I'm not saying there should never be another RCT about immunization incentives. Indeed, I am running one. But there I'm looking at exactly how low can we drive the incentive in order to still get the behavioral response. That's a very relevant question. But if I'm simply worried about can the government organize this, then maybe what I want to do is a logistics pilot. Maybe I want to just see if we can run the implementation. And for that, I need a process evaluation, not an RCT. I'm pretty damn sure that if they can hand out the incentive, more people will come. What I'm not sure about is if they can hand out the incentive. I don't need an RCT to learn whether they can hand out an incentive, right? I need a process evaluation. So we get information on local conditions to answer these questions. We draw on all the global evidence base about how humans behave to answer these questions. And we worry about local implementation, and maybe we do some logistics planning and some process evaluate, do a pilot with a process evaluation for local implementation. So let me just do a little detour and talk about what this means, I think, for literature reviews and meta-analysis. Just to be clear, a meta-analysis and systematic reviews are things that's very commonly done in the medical field and public health field. A meta-analysis combines the results of many RCTs and kind of looks at the average effect. On average, what did we get when we have 50 different RCTs that all gave people this certain cancer treatment? And whereas the literature review, which is more common in economics, is kind of a little bit more freewheeling in saying looks at theory and tries to draw general lessons across. So I do think there are benefits of doing meta-analysis. One of the things that the medical community has been very insistent on is having very clear rules of which studies you include and which you don't when you try and do a review of the literature. If we pull results from particularly if you pull results from many low-powered studies, you can get more power. If you have 50 low-powered studies, you get more power. But it kind of only really makes sense when you're when you're pooling the results from something that's exactly the same program and there's some similarity to conditions. Because, if you're kind of averaging across places where the program was implemented well and the program wasn't implemented well, I'm not really sure what you learn. Or if you, as some people have done, you pull the results for education studies where there was a computer involved, you can have really different projects in schools that use computers. Some really good ones, some really bad ones. And if you just take the average of all projects that involved a computer, I don't know what you learn. I really don't know what you learn, because we might expect those to be very different. And what we really want to understand is, how do you use computers effectively in schools? So I think this approach that I've been talking about means that we really have to use judgment about what is the theory, how do we, the underlying theory I've been talking about, I've pulled from pricing studies to, the incentive work, to the commitment savings devices, like a whole different literature testing really different projects. But the underlying theory, it all speaks to the same underlying theory. And I think we throw that theory lens out, what comes with a lot of costs. I also, use descriptive data, I think is really important to tell us, for example, that people don't spend much on preventative healthcare. That's a relevant fact. That's relevant to knowing whether my RCT is going to work, whether the evidence from one RCT is going to work in my context. So as I say, that was a little bit of a digression. Let me go through another example. This one will be quicker now. I've kind of got you going on the theory. This is an HIV prevention program, and it started with this fact. This were the HIV rates in Western Kenya by age and by gender. And what you see is that HIV rates are much higher for older people than for teenagers. And this was a program targeted at teenagers. And in particular, you see this big increase in men, very, very low rates for teenage boys, but much higher rates for older men. So if you are a woman, if you're a teenage girl, in this context, there is a lot of intergenerational sex, so where teenage girls are having relationships with older men, maybe 5 years older. This is not just something that happens in Kenya. And, partly because the older men, maybe they have a job. In the US, it would be they have a flash car. Here it would be, they take you out to, out on the town, they give you better gifts. There's something attractive about going out with a guy who's a little bit older. Now, in this context, the HIV programs were all talking about, if you have sex, you can get AIDS. Wasn't telling people about this age differential in the risk of relationships with different men. So if you're a teenage girl trading off who you're going to have as a boyfriend, you may need to trade off these better gifts with the higher risk of getting HIV. So what they did was they provided this information about the differential risks to teenage girls and boys through a school HIV program. So it was a school education program about HIV, and they added this in some schools, in a random sample of schools. And you saw a dramatic fall in the number of pregnancies with older men. Now, what's the theory of change behind that? Well, it is that older men have higher HIV rates than younger men. Like, that's kind of part of the theory. Like, if we don't have that, we don't want to do this program. That older men offer more financial protection against pregnancy. They, give better gifts. Also critical to this was the assumption that the girls knew what HIV was and that there was, roughly the mean rate of HIV, but they didn't know that older men were riskier than younger men. You're also assuming that girls are trading off the costs and benefits of having a relationship, and in particular unprotected sex. Then this is sort of the general behavior issue of increased perceived HIV risk leads to less unprotected sex. If you think the risks are higher, you're going to have less of it. And that, the implementation issue is that you can convey this information effectively to girls, and that will reduce the amount of risky sex with older men. So we presented a whole bunch of findings to the government of Rwanda, and they got very excited about the idea of bringing this program to Rwanda. And we said, well, hang on a second, let's have a think about whether this is the right context. We didn't want to do an RCT in Rwanda, partly because the rates were so small, you would have had to have done an absolutely massive, really expensive RCT to pick up any effects in Rwanda. So we said, well, let's just do a mapping of kind of whether we think this theory of change might hold. And we worked with the Rwandan Biomedical Council to do a survey of girls and understand what they know, because that's critical to the theory of change here. In particular, how humans respond to information depends on what they think at the beginning. Right? In the stock market, a company may announce good news and their stock price falls. Why? Because the good news wasn't as good as people were expecting it to be, right? We often hear that it underperforms expectations. So even if profits go up, if they went up less than people were expecting, the stock price falls. Why? Because we respond to what's different about the information from our perceptions, not the actual information, right? So what's critical is we think behavior of people depends on the change in perception. So we need to know what those perceptions are. So we found that actually girls already knew in Rwanda that older men were more likely to have HIV than younger men. It was also the case that girls massively overestimated the rate of HIV in the population. Now, they also actually overestimated it in Kenya, But in Kenya, they didn't know that older men were riskier. So in this case, they're not going to learn anything about the relative risk, but they are going to learn that actually HIV is much, much, much lower, and it's much lower in Rwanda than it is in Kenya, like, you know, almost an order of magnitude lower. So what might happen if you give them the information of HIV risks by age in this context? They might have more unprotected sex. Exactly. So knowing the local context here is really important. So we decided to tell the Rwandans we really thought this wasn't a very good idea. Like if they wanted to reduce teenage pregnancy, they might have the unintended consequences. So my last example is some work on targeted instruction, which there's a series of studies in education that have tested different programs that do different things, but one of the results that comes out of this is the common thread amongst all of these programs is that they tailor the instruction to the level of the child. So this program introduced additional teachers, and then they split the class in two, so you had smaller class sizes. And in some cases, the classes were just split randomly, and in other cases, they were based on how much children knew at the beginning of the year. In particular, teaching is in English in Kenya, and that's the third language of many children, and so how much English they knew, they were split by how much English they knew, so that the teacher could either speak in Kiswahili or in the local language, or in English, where the kids actually knew some English. This introduced tutors into schools in India, and again the class was split. The kids who were falling behind were provided with a tutor. Here the tutoring was done after school, in a project Mark and I worked on. There was a similar sort of catch-up program for kids who were falling behind, but in the summer months in India. Here, the same approach was used, but within the government schools, where students were split by how much they knew, at least for part of the day. In Haryana, the same approach was introduced in Ghana. Again, sort of providing tutoring to kids who were falling behind, sometimes out of school, sometimes in school. And this is computer-assisted learning. And again, I can add, we've had studies since I made this slide just coming out, again, using computers to tailor the lesson to the level of the child. So, you know, you start answering questions and the computer figures out, oh, they don't know this, let's go easier, or no, they're getting this quickly, let's move faster. So this kind of, I mean, this is one example, but as I say, there are other examples of using computers to tailor the level of education to the child. So it's all about the problem of that children are attending, so this is true in many cases, children attending school, but literacy and numeracy are very low. And I have to say this is true in developing countries. It's also true in some of the poorly performing cities in the US. And there's also often a challenge that teachers have incentives to teach to the top of the class, right? In many countries, you get in the newspaper how many kids pass the 8th grade exam to move on to secondary school, or, you know, got into a good college in other contexts. But often there's not much incentive to deal with the kids who are falling behind. So that's the needs, right? That's the needs assessment. This is a problem. Then there's this general behavior that that catch-up programs are at the child's level, and when it's at the child's level, a child can learn more quickly that's the basic fundamental learning behavior issue that we think is behind this evidence, that if the curriculum's up here, you're not learning. If it's at your level, you're learning more quickly. And then there's all sorts of implementation issues, and we've tested various different implementation approaches. But the things that seem to be key is, the teacher volunteer actually has to follow the program. You have to spend time on the program, and you have to have kids showing up. So, for example, in the summer programs, one of the challenges is that kids don't always show up. If you do it after school, you have lower take-up rates. So there are many implementation models for this approach. You can use teachers, low-cost tutors, unpaid volunteers, or computers. You have all sorts of questions about should it be in school and out of school, and there are, which of these you want to choose will depend on the local context. And we're going and talking to a number of countries to try and figure out, do they have a long holiday break where kids can do the catch-up? Or are the kids all working on the farm during that time and therefore they can't work? Is there time after school? These are all going to be, or are the kids traveling from a long distance and therefore they can't stay after school? So these are all going to be context-specific questions that are going to be relevant. Do you have volunteers that you can use? Some communities do, some communities don't. So we can kind of mix and match this to what is relevant in the local context. The main lesson we found is that you need some dedicated time focusing on these basic skills, and that kids have to be in groups of the same level. Interestingly, a program that was based on this idea in Chicago using volunteers was actually fantastically effective. So really, the basic, if you've got that basic underlying problem, and the same problem of kids of very different levels of education in the same class, kids are falling behind. We're talking about India, rural India and urban Chicago, but if you've got the same need, we actually find that sort of the same underlying concept can be used to, works very effectively. Obviously, how you implement it is going to be very different in Chicago than rural India. So I just want to conclude by saying, when people ask this question of, do RCTs replicate to a new context, I just think that's the wrong question. What is it that we're thinking about replication? And we've got to, instead we should be asking, what's the theory of change behind the RCTs that we might think are relevant? Do the local conditions hold for that theory to apply? How strong is the general evidence behind the behaviors that are at the center of this theory of change? And then what is the implementation? Can we pull off the implementation here? And I think that as policymakers trying to use evidence that is being generated elsewhere, these are the questions I think you ought to be asking yourself. What's the need? What's the problem that we're trying to address? Has anyone addressed that problem elsewhere? What's the theory? What are the different theories about how we can address that problem? And what is the evidence behind those theories? And then you've got to worry about implementation. And implementation is a lot of what we all have to do every day, even as a researcher. Like pulling off the survey and pulling off the implementation that we're testing is what I spend, 90% of my research time on is still about implementation. So there are studies and research about how do you improve implementation, but a lot of that is going to be very locally contextual. So we're not going to get you out of that problem. But that doesn't mean that you can't draw on this wide literature that's being generated. And if I've persuaded you of one thing, I hope it is that understanding this literature and the results of RCTs and understanding your local context are complements and not substitutes. Right? You need both. And the better you understand your context, the better you will be able to use the rigorous evidence coming out of RCTs that you do, but also that other people do. Because we often find that people are very interested in doing an RCT themselves, but there's lots out there that you can learn from as well. So it's really a waste to generate all this research and only worry about the one RCT that you're doing. You ought to be learning from all the other evidence that other people are generating. I think I'll stop there. Thank you. And I look forward to your presentation. Well, I guess we've got a few minutes for questions if you want questions. I apologize I didn't add clickers to this.
Actually, there's one thing. At the end of the Why Randomized lecture, Dan Levy, if I can find it, Why Randomize? The very last question he wanted us
To come back to?
potentially, yeah, if I can find it. Yeah.
On clickers.
So, problem is, it's right at the end of the part that he presented, but he didn't present the whole thing. There we go. Oh, so actually, unfortunately, we've lost the answers to this. But it seemed like the typical concern about RCTs were too expensive, too difficult to design. So it was like, yeah, those are, I think, the biggest critique. So it would be nice to kind of address that since we don't have any other time to do that.
So you want me to answer all of those questions?
Just the maybe too difficult, take too long, and
Yeah. So I think this is actually very related to what I've just been talking about, which is I think we do have to recognize that RCTs are quite hard and they are quite expensive. I mean, there are exceptions. I've done them for, $6,000. Google does them all the time for virtually no money by just, randomizing which list, you're seeing and how you're seeing it and seeing what you click on. But the kind of things that we're interested in about, do these programs fundamentally change people's lives? Well, that's expensive because then you have to follow their lives and you have to really understand what's happening in their lives. And that requires collecting a lot of data. So I don't think we should shy away from the fact that these things can be hard and they can be expensive to do well. And so I think the solution, the lesson from that, is we think carefully about where we do them. We don't do them everywhere. And we make sure that we learn from them, not just from that program, but we learn much more widely from the RCTs that are done. So we've really got to think of these things not just as testing one program, however important that is, but also that we're asking fundamental questions about human behavior that will generalize. And the best RCTs are ones that combine, testing a real program that's important, but also telling us something fundamental, or at least that when it's added to all the evidence from other evidence that we have, that we learn something fundamental about how people behave. And that is what helps us design better programs in the future. So, there are many big expensive programs where even a big expensive RCT, only if it helps with that one program, is still valuable. But I really think that on the whole, the bigger fish is answering questions that we can learn from more generally. And I try to give you a few examples here about how RCTs can tell us about why people aren't getting immunized, procrastination, how we can offset a procrastination. That kind of idea that people don't invest in preventative health is just true in every country in the world. So it's affecting billions of people, and this is helping us inform healthcare decisions. It can be basically brought into any health program. The idea that people are going to underinvest in preventative health and that little nudges can help them over that. It really can be incorporated into any health program you can think of. Other thoughts, questions? I just exhausted you. Yeah.
So I think what you're saying makes a lot of sense in terms of taking RCT from one context and then thinking about how does that apply to different contexts. I guess my question is, how do you think about building in some of those process things to understand more about how the context is affecting implementation while you're doing the RCT, so that you can so that it can be more generalizable and not narrow in its scope?
Yeah, so I think there's a couple of things there. There's understanding how the process worked and how well the process worked. I think that's really important in understanding. Learning from an RCT is understanding, mapping out the theory of change and having indicators at every point to see where it fell down. That can tell us a lot about why it's working and why it isn't working. And again, understanding and documenting the context in which an RCT is happening, and that will often happen in this process data that's collected, but also in baseline and attitudes and qualitative work that's done around it. But I think thinking really carefully about the theory of change beforehand and the theories of not change, right? Like the alternatives, like why it might not work or what might go wrong or how people might react, and trying to pick up indicators of those. If you're talking about, say, believe you're working on a job training program, like is it that are the skills built? But if the skills are built, but they still can't find jobs, but maybe the issues is that they have other issues in their family that are preventing them working even if they have the skills. Well, then thinking about all those other constraints that might be a problem and asking some questions about those and thinking who might be most susceptible to those. And then maybe if you see that the job training program helped the people without kids or without elderly parents that they're looking out for, or haven't had these other barriers, if you see that it helps them and not the others, well then you've got an idea of why it's not helping everyone, or whether these other constraints are issues. One approach obviously is then that people have done is say, job training and childcare, or and then you get a very complicated RCT. But even if you don't do that, you can just ask about these questions about the characteristics of people who are part of your population, and then seeing how it impacts different kinds of people will start to tell you something about what the other theories would be and why it may not work. And then if you see, again, some job training work in Latin America that has found these issues around these other constraints to people getting jobs, and that women drop out of job trainings a lot, and so they're thinking about, is it childcare and stuff like that. Then if you see that that's an issue, that the women with kids aren't benefiting, but other people are, then when you're taking it to another context, you can think, well, am I dealing with a case where the kinds of people I'm retraining are those sorts of people? Or maybe they're all, 50-year-old male steelworkers that I'm training, and therefore it's not, this childcare thing isn't going to be an issue. So just thinking about it from the beginning and collecting some data along the way that can help tease out these local conditions can really help the next group learn from it, and draw these comparisons across different studies and say, oh, well, it seems to be that where you have this kind of population, it works, and where you have this kind of population, it doesn't. The other thing that's really important, I think, is documenting in detail the program. Because in the final economics paper, it'll say, there was a job training program, and they'll have like this much of what the program actually was. Well, the next policymaker who wants to learn from that is not going to learn very much from that much in a paper. Right? So often what I try and do is publish something separately which gives a lot more detail about the program. So we provided these grants to communities in Sierra Leone where we have a lot of documentation about what the grants were spent on, for example. So there wasn't, you know, the Economics Journal wasn't very interested in that, but I know that the next policymaker who's thinking about this is going to be interested in that. Other thoughts and questions? Not necessarily about this, but about anything. Yes, David.
This was a really good thing to end on today, at least for our group, is like thinking about it backwards, kind of, and thinking, you know, what you know, a policymaker would want to be able to, or what they should want to see out of something like this, and then thinking backwards to say, oh, well, is it even worth trying to design this thing because it's looking incredibly difficult at this time? Like, you know, even if we do it, you know, who's to say that, you know, some municipality is going to pick this up and be able to replicate? So,
Yeah.
just
And
an
I think
interesting
having,
way to look at
and
it.
having in your mind not just, I want to test this program, but what am I learning more fundamentally from testing this program? I think is really important, because those are the things that generalize better. So, you know, they may have been testing what's the price for a bed net, but they were thinking about these underlying questions of access and why people don't invest in preventative healthcare, and is there a psychological boost to paying for things, was actually one of the fundamental questions that that study was looking at. Turns out, at least in preventative healthcare, it's not. You don't use something more if you pay for it. And that's similarly a sort of general question. So ideally, you test both the specific program, but you're also thinking about it in the context of the wider literature and how it fits into that wider literature, what gap it's filling in that wider literature. So where you're working with, I know a lot of people here are sort of working on the implementation end, where you're working with an academic, that's part of their role, and they're thinking about that. They may not always be talking to you about it, but I can tell you they're thinking about it, because they only get published if they can put it in the context of a wider set of studies and how it contributes to our general understanding. So that's maybe a tall order for people, but I think it's really important to get the most out of these studies, to think how it fits into a wider literature. Okay.
I think they're chomping at the bit to get it back at their project.
Okay. Okay, thanks everyone. Well, I look forward to hearing your projects tomorrow.